Hello, my name is Michael Caputo. I'm going to be presenting my pulmonary hypertension paper. Pulmonary hypertension can be defined as a hemodynamic and pathophysiological condition that is characterized by an increase in the mean pulmonary artery pressure. There are 5 different groups of pulmonary hypertension. It can be classified into 5 groups. Group 1, pulmonary arterial hypertension, can be hereditary or idiopathic or associated with a lot of underlying conditions. Group 2 is pulmonary hypertension due to left-sided heart failure. Group 3 is pulmonary hypertension from lung disease. Group 4, chronic thromboembolic hypertension. This is rare because it's caused by blood clots that don't dissolve in the lungs. Group 5 is pulmonary hypertension with unclear or multifactorial mechanisms. The way that we can measure pulmonary hypertension is by knowing or estimating the right atrial pressures. We have to measure the inferior vena cava. If it's over 2.1 centimeters, then it's considered dilated. If it doesn't have a collapse at all, that's also going to indicate increased right atrial pressures. If the IVC is dilated without collapse, then we're going to estimate the right atrial pressure to be 15. If we have it dilated but it is collapsing, then we're going to estimate the right atrial pressure is 8. And if neither of those things is not dilated but it is collapsing, then we're going to estimate the right atrial pressure to be 3. Another way that we find indications for pulmonary hypertension is finding the peak velocity of tricuspid regurgitation. We can also use the pulmonary acceleration time, which is achieved when we're looking at the pulmonary artery. We use PW in the pulmonary artery in one of the Doppler signals you measure from the baseline to the peak. And if it is measured with an acceleration time of less than 90, that could be an indication of pulmonary hypertension. 90 meters per second. Pulmonary artery pressures are usually equal to the RV systolic pressures, which makes finding the right ventricular pressures the most important finding when dealing with somebody with pulmonary hypertension. The way that we find this is we, again, measure the tricuspid regurgitation peak velocity. A patient with pulmonary hypertension may present with shortness of breath. That's the most common. All of the patients are gonna complain of that. Other early symptoms are fatigue, chest pain, a racing heart, pain in the upper right abdomen, and a decreased appetite. In the more advanced stages of pulmonary hypertension, we're looking at dyspnea on exertion, possible fainting or cyanosis of the lips or skin, and lower extremity edema. When we're thinking about lower extremity edema, we have to understand that if it's only one side, that it could be a DVT, a deep vein thrombus. If it's both sides, then we have to evaluate the right heart for failure if the function is compromised. Some echo findings that we're going to see is, of course, tricuspid regurgitation. We've been saying that a couple times. The right atrium can become enlarged, RV thickening due to the increased workload. The D shape in the short axis, the septum is going to be pushed down. And the dilated IVC with or without collapse. Just got to measure that. And then I had one thing more. I don't think so, actually. It's great. Hope you read the paper. Hope you enjoy it. Happy Mother's Day. Enjoy. Thanks for the class.